Now, among the major subjects and among the minor subjects, there are various important questions which are invariably asked. In a series which we are just dealing with is the most important questions, the most important topics which have been asked and which are highly likely to be asked in future. Now, as far as dermatology is concerned, dermatology happens to be a minor subject, but there are certain topics in dermatology which are almost always asked in any examination. As far as NEET PG examination and FMGE is concerned, you have to remember that there are topics like tuberculosis, there are topics like sarcoidosis, there are topics like connective tissue disorders, which happen to be examiner's favorite. And especially from dermatology, there is this one topic which is asked very frequently. And the topic chosen today is psoriasis. Now, as far as psoriasis is concerned, you have to remember that this psoriasis is examiner's favorite. And now, as far as the psoriasis is concerned, it is a disorder. A disorder of what? It is a disorder of epidermal proliferation. That means what happens? There is hyperproliferation of the skin, as a result of which there are multiple layers found, and the topmost layers of the skin are derived of nutrition, and the basal layers get more of a nutrition. And what happens? The skin presents with a characteristic scaly eruption. The skin of a human being resembles the skin of a fish. That is why we give the name as silvery scales or plaques, which are distributed especially on certain areas of the body, which I will be dealing subsequently. So you have to remember fish-like scales. Very important, fish-like scales, and they can be widespread on any part of the body. And there are some parts which are having a predilection more than the other parts. But over here, have a look at the figure, and this can be asked as an image-based question. So what you are seeing over here is a plaque, especially on the front. It is the front of the scalp, and you see a plaque over here. In here, you are seeing the plaque at the knees. So characteristically plaques at various sites, and in here you have a plaque of different type which is present on the lateral aspect of the face. So you can be having plaques at different parts of the body. Now, as far as the presentation is concerned, naturally, as I mentioned, scales or plaques or any part of the body, but usually on the extensor aspects. Classically, a clinical scenario will be given to you with plaques or silvery scales on the extensor part of the body, not the flexor part. And the common site along with the extensor parts of the body is the scalp. That's very important. So silvery, and this disease usually presents in a symmetric manner. And as I mentioned, extensor aspects, so that is very important. Now, in addition to that, there are certain other features which are asked from a pathological viewpoint, especially the micromunro abscesses, which we will be dealing in pathology. So remember micromunro abscesses pathologically. Now, the psoriasis does not affect only the skin. It is characterized by affection of other body parts as well, especially the nails. So the skin along with the appendages, the nails especially, are having features. And what are the features in the nails? They are pitting, oncholysis, oil spots, and salmon patches. You have to remember these characteristic nail changes associated with psoriasis, which I will be showing you in figures ahead. An important point is a phenomena, a very interesting phenomena which we give the name as Koebner's phenomena. That means at the site of trauma or wherever you rub the skin in a psoriatic patient, there will be appearance of psoriatic lesions at the site of rubbing or site of trauma. And this is a feature which is given the name as Koebner's phenomena. And this Koebner's phenomena is not seen in case of psoriasis only. It is seen in other conditions as well, but here remember that Koebner's phenomena is associated with psoriasis. And what Koebner's phenomena is, that I just mentioned. In addition, you can remember that many a time psoriasis is associated with psoriatic type of arthritis. So a patient with psoriasis can present with nail changes and the changes on the skeleton in the form of psoriatic arthropathy. So if you have a dermatological patient presenting in a dermatology clinic with psoriasis, you have to examine his nails and you have to also examine to a musculoskeletal survey of the psoriatic patient. That's important. Now over here you can have a look. This radiograph shows a marked deformity and restriction, and there is what we call, you have to remember the term arthritis mutilans. And what is arthritis mutilans? It is a severe type of a deformative erosive arthritis which is classic of psoriatic arthritis. In case psoriasis is allowed to progress, the arthritis can be severe and of a deforming variety, and you have to remember this psoriatic arthritis and a severe form given the name as arthritis mutilans. Very important and examiner's favorite. In addition, over here you can see this over here, the pitting of the nails. So you have characteristic pitting of the nails. Small pits appear in the nails. That is given the name as pitting of the nails. So you have to examine the nails for pitting. Now, pathology, micromineral abscesses, as mentioned initially, as well as elongation of retinal regions, in addition to dilatation of blood vessels. So, there is vasodilatation, and there is, in addition to that, epidermal and perivascular lymphocytic infiltration in chronic and long standing cases of psoriasis. So, what are the fundamental features common to psoriasis? And it is common in men and characterized. There is one important thing about psoriasis. It is characteristically characterized by the presence of remissions and relapses. That's important. And external factors, infection, stress, and certain medications can just exacerbate the condition. And what are the medications you have to remember? There's a long list, but lithium and antimalarials, they precipitate psoriasis. That's important in addition to stress and infections. So that's very important. Streptococcal infections or respiratory tract, especially the upper and the lower respiratory tract infections, they can predispose a patient to psoriasis. That's important. And the typical lesions are well demarcated erythematous raised plaques or papules or silvery scales. That's important. Now, there can be many variations of psoriasis as far as images are concerned. So there are various types of psoriasis. One is the guttate psoriasis, the second is the erythrodermic psoriasis, the third is the inverse psoriasis, and you have to remember what we mean by these types of psoriasis. So number one, in a normal case, as you can have a look at this figure, this is a figure, you can see it's a back and you can see characteristic demarcated cervical plaques on the back. So this is a simple case of psoriasis. And over here, this is a large erythematous. You can see in this second figure over here, this is a large and a big patch of psoriatic plaque, which is reddish in color. And this is a type of plaque psoriasis. What it does, it creates a plaque on the surface of the body, and this is a more pronounced type of a psoriasis in which there is a characteristic plaque formation. And over here, you can see this is not a single patch, there are multiple confluent patches which just arise and come together, and this is a confluent psoriasis in small plaques joined together. And over here you can see there is a characteristic redness and there is some denudation of the skin as well. So this is some type of a erythematous psoriasis which is of general pustular type. You can see pustules over there in this. So you have got erythrodermic psoriasis, guttate psoriasis, and pustular psoriasis. That's very important. Now, as I mentioned at the onset, the psoriasis especially affects characteristically the extensor aspects. And there is one term which you have to remember: inverse psoriasis. What is inverse psoriasis? Inverse psoriasis is the presence of psoriasis not on the classical extensor aspect. It can be present on the flexor aspect, or it can be present in the inguinal and the axillary regions. So psoriatic lesions present characteristically in armpits or the groin, in the inguinal and the axilla, other than its association on the common extensor aspect, is given the name as inverse psoriasis. So that you have to remember. So usually psoriasis affects the extensor aspect of upper and lower limbs. That's important. In addition to the scalp, you can have psoriasis in the lumbosacral limbs and the elbows and the knees as mentioned. Now, scalp, as I mentioned, is also affected. The face is also affected, and the tongue may be affected. And you can have rough patches of the tongue, and the areas marked. Some are normal, and that's given the name as geographic tongue. So, areas of normal and subnormal mixed together, you can well demarcate the normal and the abnormal portion of the tongue. That is given the name as geographic tongue. Now, characteristic lesions. What is important? Smaller plaques are discoid and they sometimes merge to form gyrate lesions. Very important. Central clearing results in annular lesions. That's important. And I mentioned you, any patient who just goes on rubbing the skin can develop psoriasis at those sites of trauma. That's the Cobnus phenomena. And that Cobnus phenomena is tested by virtue of multiple tests. Psoriasis has got many eponyms associated with it, and there is this positive auspit sign, the candle grease sign, and the grattage test, which are almost having the same mechanism, but you have to remember those eponyms: auspit sign, grattage test, and candle grease sign associated with psoriasis, along with one entity pathologically I mentioned you, the micromunro abscesses in the pathology. So that is very important. And these lesions are variably pruritic. Some patients present with intense pruritus, and some patients with moderate, and some do not present with pruritus as a whole. And so you have to remember that they are pruritic and they can be having hypopigmentic halo or war of rings. So that's important. Pruritus is a variable factor. Now, as far as the nail changes are concerned, I mentioned you that nail involvement is common in many patients, and we can be having pitting of the nails or the nail plate thickening or tunneling and subingual dermis and oncholysis. That is the destruction of the nails. So nails can be having destruction of severe or varying degrees. In severe cases, you can be having total oncholysis in case of nails. And as you can see over here, this is the nail, and over here you can see that there is a characteristic pigmentation oil drop sign, local oncholysis, and over here you can see generalized oncholysis and subungual hyperkeratosis. That's important. So these things are to be remembered as far as the nails are concerned. Psoriatic arthritis important. I mentioned you severe variety called as arthritis deformans, and you can have having almost 10% of cases having the orthopedic association of psoriasis. And what is the type of arthritis? It is usually polyarticular, it can be monoarticular, or it can be rheumatoid arthritis like variety, especially why rheumatoid type, because it usually affects the smaller joints. So the smaller joints are more commonly affected rather than the big joints. As I mentioned, the guttate type of psoriasis eruptive is having very, very small lesions, multiple lesions, I mean to say present, covering a wide area, and they usually follow an infection, upper respiratory tract or a lower respiratory tract, typically streptococcal pharyngitis, which can be also a precipitant factor in causing of psoriasis. Number second, pustular. You have pustules on various body parts, or you can be having it on them on the palms and soles, and they will be associated with fever and leukocytosis. Erythrodermic component, red element coming into the psoriasis, and that is why it is given the name as erythrodermatic. And so edema and scaling of different body parts in different proportions. That's important. So over here again, I just reiterate that many patients present with psoriasis of different degrees in different manners and at different areas. So you have to be well aware of the different clinical cases which can be given to you as clinical psoriasis. So again over here, this over here shows a well demarcated patch on the knee. It should not be able to miss such a question. This is pustular, small pustules formed over here, and over here this is guttate psoriasis, multiple small psoriatic patches on the back, you can see it. And this is the erythrodermic type. Over here, this figure shows the erythrodermic type of psoriasis. So you can see the erythema over there, the redness, and this is guttate, multiple erythrodermic patches on the back. So you have to recognize psoriasis in all the forms. So that is very important. Now, what are the various HLAs associated with psoriasis? A question again asked many a times. So BW17, B13, and BW37. This is the characteristic HLA association of psoriasis. HLA associations are asked in many questions, say the dermatitis herpetiformis, say rheumatoid arthritis, and this is one clinical condition wherein you have to remember the HLA association. Now, treatment part in the past used to be messy. We used to use coal tar and sulfur preparations for the treatment of psoriasis, but now there is, with the advent of new drugs like calcipotriene, which is a vitamin analog, and you have to remember that calcipotriene ointment is nowadays given for treatment of psoriasis. Retinoids to a varying extent can help in psoriasis, and PUVA therapy, phototherapy with ultraviolet A or ultraviolet B especially, is given in case of psoriasis and has found to be beneficial effects. Now, in addition, you have to remember that we give some drugs which are typically used for other conditions and which are antimitotic drugs, and especially drugs like methotrexate, azathioprine, and hydroxyurea. They have been found to be beneficial in some and severe cases of psoriasis. Psoriasis is usually treated by specialist dermatologists, but you have to remember that psoriasis can be treated by these groups of drugs, and they are given under I mean to say supervision. So methotrexate, azathioprine, hydroxyurea, and simultaneously you have to note for the side effects of these drugs, which can cause profound immunosuppression and bone marrow depression as well. So that's important. Retinoids, as I mentioned at the beginning, eternate is given is retinoids are various forms are given in the treatment of psoriasis. Now, additionally, lately it has been found some biological agents like the elafacect and ustekinumab, etanercept, infliximab, and adalimumab. They are lately given for the treatment of psoriasis. But one question which has been asked frequently is the main mechanism of action of these drugs. As far as elafacect is concerned, you have to remember that it attaches itself. It is basically a leukocyte function associated antigen 3. There is this LFA3, and the elafacect blocks this LFA3. So that is very important. So by blocking it, it has been found to have a profound effect on psoriatic patients. Ustekinumab is another new drug which is basically interleukin 12 and interleukin 23 inhibitor, and the mechanism has been asked. It is lately tried in specialized centers under supervision, and this is a drug which has been found to have a profound effect in the patients of psoriasis. Etanercept, you have to remember that it is a TNF alpha and a TNF beta blocker, combined TNF alpha and beta blocker. It is very effective in treatment of psoriasis. In addition, infliximab and this drug which I mentioned at the last, adalimumab, and adalimumab is characteristically a TNF blocker as well, in addition to infliximab, and they are both given in the treatment of psoriasis. So just to wind up, as far as the psoriasis is concerned, this is an important clinical entity you have to remember. I hope this class benefits you a lot. Thanks.